Our subject is head and neck surgery. We're joined by an awful lot of very illustrious guests tonight. This session is being kindly hosted by our Vice President, Professor Laura Vianney. As always, keep your microphones on mute, avoid any feedback, and indeed keep your cameras off unless you're happy to share any embarrassing photos. So that's the housekeeping dealt with. I hope everybody's keeping well. We've obviously moved into a different phase of the lockdown. That's going to have its own impact on provision of services and care for patients and travel and everything else, and it's just going to make life a little bit harder than it already was. But nonetheless, I think everybody's still quite resilient and ready to go, and it'll be interesting to hear the approaches here from ENT. The various challenges, I suppose, that are out there maybe at the moment as well will be a welcome mention. So I'm going to hand over to our Vice President to introduce our guest speakers. Thanks, Laura.
So good evening to everybody, and likewise I hope you and your families are all well. So it's a great pleasure to welcome you to tonight's webinar, which is an update on head and neck surgery. We have two speakers and a moderator. The first speaker is James Paul O'Neill, who's well known to you all. Paul is a college graduate, a fellow of the RCSI. He spent 2 years on a cancer fellowship at MSK, which is Memorial Sloan Kettering from 2010. And he took up a consultant post and professor of otolaryngology in Beaumont and RCSI in 2014. Paul has many publications and many awards and is a leading light in our otolaryngology community. We're also delighted to welcome our guests, and we're very privileged to have you, Dr. Luke Morris, join us this evening. And Luke is Associate Professor of Surgery at Memorial Sloan Kettering and Associate Director of Immunogenomics and Precision Oncology. And he's a clinical scientist specialising in head and neck surgical oncology and cancer research. His clinical practice is focused on surgical care for cancers of the head and neck and thyroid. He's Associate Director of MSK's Immunogenomics Precision Oncology, as I've said. He's also the Director of Fellowship Training. He's on the editorial board of Cancer, Thyroid and JAMA Otolaryngology. And he is a principal investigator in many cooperative groups, industrial analysis in several cancer types. And he's also many publications, over 150 publications. So you're most welcome to us this evening. Mr. Neville Shine is going to moderate the session. And Neville is a consultant otolaryngology and a colleague at Beaumont Hospital. And Neville has done fellowship training in Perth and in Cape Town. And his subspecialty interests are thyroid, skull-based surgery and facial plastics. So he's well based to moderate the session this evening. So with that, Neville, I'd be very grateful if you would take over the session and introduce our speakers.
That's great. Thanks very much, Laura. So first up, we're going to have Paul, and then we will run through the second presentation with Luke, and we'll take questions then at the end. Get involved in the meeting chat function. You can type questions in, and we'll pick up hopefully some really good questions to challenge our two presenters. So Paul, if you'd like to start. Medullary thyroid cancer, it's a rare and challenging disease that really demands the highest quality of surgical care in a multidisciplinary format. So I think it's a great topic. And without further ado, Paul, if you take the floor.
Okay.
Paul?
Can you see the slides?
We can.
We can see the slides, yeah.
Perfect. Okay, so good evening, ladies and gentlemen. Could I firstly start by saying thank you to Vice President Laura Vianney and also to Neville Shine. I'd also like to welcome the SC1 students who had their first ENT lectures with us in Croke Park the other day, and I know a number of them have joined us this evening. And finally, to thank my great friend Luke Morris, and thank you for joining us today and for all the support that he's given our program over the last few years. So medullary thyroid cancer, as Neville said, this is a fascinating topic. It's not one that we talk about that often. We don't see this cancer routinely, and We've had a number of cases in recent times which prompted us to put together a review presentation on this. So let's go straight back to the beginnings. So we develop the thyroid very early in utero because, of course, we need the diesel of the body, which is thyroxine. So the thyroid originates from two main structures, the primitive pharynx and the neural crest. The rudimentary lateral thyroid develops from neural crest cells, while the median thyroid, which forms the bulk of the gland, arises from the primitive pharynx. So for the next 3 weeks following this then, the primitive thyroid tissue penetrates the underlying mesenchymal tissue and descends along the thyroglossal duct tract. The thyroid initially is spherical in shape and it changes to a bilobed appearance as it enlarges. And it reaches its final destination in the pretracheal location by the end of the 7th week of gestation. The thyroglossal duct retracts. Approximately it retracts at the 5th week, and it can be identified in most adults as the permanent pit at the apex of the sulcus terminalis in the dorsum of the tongue known as the foramen cecum. Distally, the duct forms the pyramidal lobe of the thyroid gland, and this can be an area where we can leave disease behind, or certainly we can leave thyroid tissue behind. It's quoted at about 55% of patients will have an identifiable pyramidal lobe. I have to say, I would think it's much higher than that. In general, if you go looking for it, you'll find it. And it's important to remove it because obviously it could impact on your thyroglobulin levels in a well-differentiated scenario, or your endocrinologist or your radiologist could come up to you some months after surgery to tell you there's recurrence in the central neck when it's not recurrent disease. In actual fact, it's just residual pyramidal lobe. But back to our thyroid, by week 12, we have a fully functional gland. Now, part of the thyroid, as I said, originates from the 4th and 5th pharyngeal pouches. The neural crest cells, which involve or have the ultimobranchial bodies of these pouches, contribute to the parafollicular C cells. The C cells are named because of the calcitonin that they produce and also CEA that they produce. And they account for up to 1% of thyroid cells. These cells are found throughout the thyroid gland, but are mostly located in the posterior upper third of the lateral lobes. And this is where the majority of medullary thyroid cancers are found. Now, just as you are programmed to develop at an early stage a thyroid gland, equally, and this is why medullary is so fascinating, you can be programmed to develop medullary thyroid cancer at an early age, and there are multiple reports of children by the age of 10, 12 years of age dying of metastatic disease from medullary thyroid cancer. This is a picture of a 7-year-old child who has presented with these, without giving it away, what type of MEN. This is MEN2B, and you can see these mucosal neuromas here, and that was all the child had. The MEN2B was identified, the child had surgery and already had 3 foci of medullary thyroid cancer. So how does this disease normally present? Well, it can present in a number of ways. Diarrhea, which of course is the main issue with calcitonin, and indeed for patients that are treated for medullary thyroid cancer who have recurrent or residual disease, hypercalcitonemia can result in intractable diarrhea, many patients ultimately dying of this. So diarrhea, a thyroid mass, or cervical lymphadenopathy can be presenting findings. The gender distribution is equal. In terms of sporadic patients, these tend to be unifocal disease, older patients, 4th to 5th decade. The inherited forms of this disease tend to be multifocal. For example, the 7-year-old that I just mentioned. Familial or multiple endocrine neoplasia type 2A typically presents in the 3rd decade, with most MEN2B in the 1st or the 2nd. And as mentioned previously, from an embryological perspective, the upper lobe nodule is common, with 50 to 75% metastatic cervical nodes will be initially, if they're presented, will be in the level 6 area, and up to 15% airway compression or invasion. These are rare cancers, about 3% of thyroid cancers. They can overall would be considered to be aggressive disease, certainly compared to well-differentiated thyroid cancer, with a 50% survival overall at 10 years. Surgery remains the best treatment. And not just surgery, a meticulous surgery remains the best treatment for this disease. In the sporadic, about 75% of all cases will be sporadic. However, approximately 50% have somatic RET mutations, and they may have a hereditary disease identifiable in up to 7 to 15% of cases. And clearly, this has implications for genetic screening and genetic testing. In the familial component, it's about 25%, MEN2A being over 50%, MEN2B being rare at 5%, and the remainder being familial medullary thyroid cancer. This is our timeline in terms of when we discovered this fairly recently. German literature in 1906 by Jacquet first described it. By 1959, we had the first definitive histological description. 1961, Sippel published the first case report of the association of thyroid cancer with pheochromocytoma. 1966, Williams suggested a C-cell origin. By 1985, the big step forward, of course, being the RET mutation being identified. And RET is a remarkable oncogene. It's not only central to the development of sporadic and hereditary medullary thyroid cancer, but to other malignant and non-malignant diseases as well. For example, chromosomal translocations activating RET occur in 20 to 30% of patients with papillary cancer. Activating RET translocations also occur in patients with lung adenocarcinoma, with CLL, and also with benign conditions such as hereditary or sporadic Hirschsprung's disease. By 2001, the RET oncogene classification system put in place was based on your genotype-phenotype correlations. And with your MEN syndromes, of course, MEN2A is where you have medullary associated with parathyroid hyperplasia associated with pheochromocytoma. The MEN2Bs being the medullary thyroid carcinoma associated with mucosal neuromas and pheochromocytoma. But there can be other manifestations associated with this as well. With the MEN2A, you can see there the cutaneous lichen amyloidosis on the back of a patient. And with the MEN2Bs, the patients can have a marfanoid habitus. They can have both cutaneous and mucosal neuromas, and you can see the child I previously showed. And then above there, you can see mucosal neuromas here in the larynx and the postcricoid face. And then finally, the association with megacolon as well. These are the codons associated then with the various diseases. The RET proto-oncogene encodes a transmembrane receptor of the tyrosine kinase family. And nearly all MEN2A, 2B, or familial medullary thyroid cancer have RET germline mutations. As I said previously, approximately 50% of sporadics will have a somatic RET mutation. The highest risk category are the MEN2B with the RET codon M918T, and the highest risk category for the MEN2 with the RET codon C634. And this clearly has implications for when we have prophylactic operations on children. You can see prophylactic thyroidectomy for MEN2A and familial by the age 5 or 6, and MEN2B in the first year due to early onset. Indeed, with the MEN918 mutation, surgery less than 6 months old. That, of course, brings up additional challenges, in particular in relation to calcium. It can be exceptionally difficult to identify parathyroid glands in an infant of that size. Because a central neck dissection in children as well as in adults is a major cause of hypoparathyroidism, if we look at the ATA guidelines from 2015, they suggest that children with MEN2 who have been decided to be submitted for a total thyroidectomy can avoid a prophylactic central neck dissection when calcitonin values are less than 40 picograms per mil and if there's no evidence of any lymph node metastases. Now, the other important area to consider with this disease is the propensity that medullary thyroid cancer has for involving the cervical lymph nodes. And even in a T1 setting, we know that about 17% of the central neck lymph nodes will be involved and up to 10 or 15% of the lateral neck. So lymph node metastases most commonly spread to the central nodes, followed by your level 3 and level 4. Less commonly, it's going to be your level 2A or your level 5 nodes. The upper deep jugular and spinal accessory lymph nodes in level 2B are affected less commonly, and lymph node metastases to the submandibular, submental, and retropharyngeal region are rare. And we can see here in particular in this picture our level 6 area, which is extending down the thoracic inlet, and then from a thoracic inlet down to the artery are level 7. So it's essential that in these scenarios, in these cases, that patients have a total thyroidectomy followed by a central neck clearance. So you need to be comfortable doing central neck clearance and or doing a lateral neck clearance. And of course, berry picking is a big no-no in thyroid cancer surgery. If we're going to do a compartmental surgery, then we do exactly that. Here's an example here, the left central compartment, you can see the recurrent laryngeal nerve. Right central compartment, again, we can see the right recurrent laryngeal nerve. And in terms of doing a lateral neck dissection, well, a modified radical neck dissection or a selective neck dissection, we pull back our skin, we raise our platysmal flaps, we lateralize our sternocleidomastoid muscle. When we're starting up the level 2 area, we must be able to identify the internal jugular vein, the posterior digastric, and our spinal accessory nerve, making our way down along the fascia, and we stay superficial to the what I call the slimy layer. I think I picked that up from the Memorial guys, but basically you want to stay above the deep layer, the deep cervical fascia, because of course if you do that, then you'll protect the phrenic. Down to the bottom of the jugular, and then following the omohyoid muscle up to the hyoid, and your dissection is complete. So how do we work up these medullary thyroid patients? Well, as ever, as I was saying to our medical students the other day, we start with a full history and a full examination. Blood work can include calcitonin, CEA, our calcium levels. We may also be checking our urines. We check for a flexible scope for the recurrent laryngeal nerve integrity. And then there's a number of different radiological investigations that we can perform, starting with a simple ultrasound to cross-sectional imaging, which may be a CT or a PET-CT scan. PET-CT scan useful certainly to determine if there's a pheochromocytoma present. MRI scans of the liver, bone scintigraphy, and ultimately when surgery is performed, then a RET mutational analysis. And we really need to assess for mutational analysis on all of these medullary thyroid cases. So this is just one example here of a recent case, a 54-year-old who was referred from an outside institution, had a left-sided swelling and left-sided cervical lymphadenopathy. There was a needle test from outside, which was registered as a Thy3A. A repeat biopsy was focally positive for calcitonin, so we checked the plasma calcitonin levels and found that it was 27,000. So clearly this patient had a high burden of disease plus or minus metastatic disease. And when we performed a PET scan, we could see that you could see significant uptake within the thyroid, but also there was significant lymphadenopathy, bulky lymphadenopathy on the ipsilateral side of the tumor, extending down into the level 7 region of the neck. So following discussion at MDT, a decision was made to proceed with the total thyroidectomy, to perform a bilateral central neck dissection and a left lateral neck dissection. And this is just a short video showing you the innominate artery here. So you can see we've gone all the way down. We had our cardiothoracic surgeons on standby in case we needed to split the chest in order to get a sufficient clearance. We're just showing you the nerves here. You can see the left recurrent laryngeal nerve now in a sec. That's extending there. Quite a big man, and thankfully we have clearance. All of the disease was left-sided. They should have no disease that was appreciable on the right side. So bilateral necks, and then we proceeded as per the scans on the left side of the neck, our clearance. So what did we find? Well, the patient had a 41 millimeter tumor. There was no gross extrathyroidal extension. Of 38 lymph nodes, 16 were positive. And you can see the levels that they were in. And bulky disease as per the scan. In fact, in the level 5 region, the largest deposit was 65 millimeters in size. We then checked for our mutational status. 18 to 80% of sporadic medullary thyroid cancers lacking somatic RET mutations have somatic mutations of KRAS, HRAS, and rarely NRAS. And in this patient, indeed, we found a KRAS mutation. So let's stage the patient then. So we have a specific staging as per AJCC for the thyroid. So we had in this scenario a T3 disease, which was just over 4 centimeters in size. And we also had a disease in the lateral neck, central and lateral neck, an N1B. So overall, this amounted to a stage 4A tumor. And I put beside that, as per the ATA, the survivals that we can appreciate depending on the initial stage at diagnosis. So 16 cervical nodes positive. What does that tell us? It tells us that biochemically we will not be able to cure this patient. And we know that over 10 lymph nodes involved, it is unlikely you would be able to biochemically cure a patient. If we look to this famous paper in relation to cervical lymphadenopathy, among patients with lymph node involvement, those with the most extended disease could not be cured by surgery alone. And this may indicate other treatment modalities such as external radiation therapy to the neck when calcitonin levels remain elevated after surgery and in the absence of distant metastases. So what about external beam radiation? So we have a lack of prospective trials in relation to external beam. This was a study which is back to 2010 from the Surveillance Epidemiology and End Results Program analysis, and they found no survival patient in benefit in patients with medullary thyroid with positive lymph nodes. But there are other studies that may indicate that it would have a reduced recurrence rate in this scenario. And what you have to balance is the high risk of recurrence versus not irradiating and reoperating, and the reoperation may be easier in the non-irradiated neck. And of course, we have a highly sensitive tumor marker to follow the patient with. So these are the issues that we need to debate. And I don't feel that anyone has any definite yes or no as to what's better in the MDT setting. In our case, we decided to irradiate, to put this patient forward for external beam radiation therapy. What about targeted treatments? So classical cytotoxic chemotherapy for advanced metastatic medullary thyroid has shown limited response and for a short duration. So after about 2005, increased interest began to develop, in particular looking at the RET mutation, looking at VEGF, and looking at EGFR in the subject or in the context of medullary thyroid. Cabozantinib is the second Food and Drug Administrative approved and European Medicines Agency approved drug for the treatment of advanced and progressive medullary thyroid. The approval arrived in 2012 in the States and 2014 in Europe after very good randomized phase 3 study in which 330 patients with advanced and progressive medullary cancer were randomized either to cabozantinib at 140 milligrams or placebo. This was the exam trial. The prolongation of progression-free survival of patients treated with cabozantinib with respect to those treated with placebo showed a significant difference. These results indicate that certainly cabozantinib can be successfully used as either a first-line or a second-line treatment, and also the drug that would be talked about a lot would be vandetanib. However, both drugs do not seem to be able to prolong overall survival in these patients. So what do we know? Well, in terms of following these patients going forward, calcitonin is king. In our patient, we went from 27,000 down to 1,410. This was the second recording was week 1 post-op. Now we know from ATA that we have to wait for 3 months, which will give us a better understanding of where we are in terms of our post-op calcitonin levels. And what happens with that calcitonin will be very significant. If we have a doubling time less than 6 months, then the implications for survival are stark. We can see here at 5-year, 25% survival to 8%, 10 years. Whereas a doubling time is 6 months to 2 years, a longer doubling time, we can see an improved survival at 92% and 32%. So in conclusion, medullary thyroid cancers should be treated in specialized high volume centers. What's a high volume center? There's no definite number, but if we look at the literature overall, probably centers where we're in excess of 100 thyroids a year. Certainly as part of the general surgical or head and neck group, people need to be comfortable doing neck dissections because it's a key component to this surgery. These are rare cancers and unfortunately are often advanced upon presentation. They can be sporadic or they can be familial. Once an index case of a family is recognized, all first-degree relatives should undergo the REF genetic screening. And total thyroidectomy and at least a central neck dissection is overall what is recommended at this moment. Calcitonin is the most specific serum marker for MTC, and its doubling time is one of the most important prognostic factors, both for survival and progression of the disease. So thank you very much, ladies and gentlemen. I'll hand you back to Neville Shine. My thanks again to Luke Morris for joining us. This is a picture of Luke, his wife Jenny, and my wife Katrina, and thanks to Luke for all of the support that he's given our program. So thank you.
Thanks very much, Paul. That was fantastic. We'll take questions at the end, as I said, so we'll move along now to Luke, who at this time of year would generally be getting himself in training for a trip over to Ireland for our head and neck course. Unfortunately, there'll be no trips over for the foreseeable future, but we're delighted to have him. He's going to talk to us about immunotherapy and precision oncology. It's really fantastic area, and Luke is one of the world leaders. So Luke, if you can take it away there, that'd be great.
Thank you so much, Nev. Can you guys all see my slides and hear me okay?
Yep, that's great.
Thank you. So thank you, Dr. Vianney, for the very kind introduction and for the invitation to speak to you all across the way in Ireland. And Paul, that was a tough act to follow. Great review of Medullary. So we're surgeons, but of course we're oncologists as well, and we want to be comfortable doing beautiful surgery that Paul showed you, and we also want to have some familiarity with where the field is going, with where oncology is going. And so I thought this would be a nice complement to Paul's talk about the clinical management of medullary thyroid cancer. You can see how conversant Professor O'Neill is with the molecular genetics of medullary thyroid cancer, because that affects how you do your surgery. It affects how you counsel your patient who's in your office and is nervous about their diagnosis and is looking to you as an authority on their disease. And it means that as clinicians, we all have to be conversant as well with where the field is going in terms of precision oncology and immunotherapy. And so I thought I would talk about these issues for a little bit. And I'm going to focus on, if it's okay, things that I've gotten a little bit wrong over the years. And if you've seen people like myself who are clinician scientists who are enamored with the genomic revolution and with the immunotherapy revolution, sometimes the hype gets the best of us. And so I'm going to talk about things that I have not quite gotten correctly. As Mark Twain said, it ain't what you don't know that gets you into trouble. It's what you know for sure that just ain't so. And what is so perfect and so meta about this quote is that Mark Twain, the author, never actually said this. It was made up and it was attributed to him, but it is so perfect. So we're all around the world. We're bound by this pandemic, and it's not the subject of my talk tonight, but it's what got me thinking about something, and I'll explain how this got me thinking about hype in medicine. So this is where we are currently in New York City, and we've been following the news from Ireland as well in the last few days. But I want to take you back to April, because this is where we were in April. Things were spiking quite alarmingly here in New York, and we had largely shut down our clinical operations here at Memorial Sloan Kettering, where I practice. And so I'm sitting at home doing only the most essential surgeries and largely at home with my kids who are out of school, and we're watching the storm approach. And it was a very anxious time for us all around the world, because at some point all of us were in this boat together, and we're still in this boat together. And here I am with my first Zoom lab meeting, and we're all kind of nervous and confused about what's happening. And I was telling everyone, I think we're just going to write off the year because I don't see the end to this. And at some point, while sitting at home and being driven crazy by my kids, I was watching the news around New York, and this is late March. Things really were surging in a very alarming way. And I'm watching the news. Here are the morgue freezer trucks pulling in outside of all of the hospitals in New York. People were describing one part of New York City, which is Queens, as the epicenter of the epicenter. And so if I can show you here in a map of New York City, we're over here at Memorial Sloan Kettering, and this area here is Queens, where the numbers were just through the roof. And it was hard to sit by and watch this happen while our own hospital was reducing operations. I ended up going out to a public inner city hospital in Queens in early April, and here I am showing up for my first day with 2 N95 masks given to me to last the week, and a pair of scrubs. And I pitched in as an ICU attending at this hospital. And the story is a story for another day that I'm not going to get into tonight. But here's the 7-bed pop-up ICU in a converted recovery room that I ran with some residents and some nurses. And it was complete chaos. It was a complete war zone. There were more patients than there were beds. There was a very high rate of death. Okay, how does a head and neck surgeon who operates on a very small part of the body know what the heck to do and how to be useful in a situation like this? And the truth of the matter is that I had to refresh a lot of very old knowledge from residency, from the old school ICU training we had in surgery during residency. And a lot of things haven't changed. The subclavian vein is still in the same place as it was back then. But I'll tell you that the training I got in residency was not state-of-the-art ICU training. That already was outmoded. And it was probably knowledge from the late 90s, which was the ICU training I used to manage my patients as a resident and haven't thought about since. And then here I am in 2020 at this hospital's ICU, and then later a few weeks at my own hospital's ICU where I was redeployed during the surge. And it's almost this Rip Van Winkle moment. That's the fable of this guy down here who falls asleep for 20 years, where I had knowledge from the late 1990s that I was now applying in 2020. You never get this experience in medicine, to just kind of go to sleep for 20 years and then come back. And you kind of realize some interesting things. It gave me the opportunity to revisit some of the aspects of personalized medicine that we embrace as physicians because we want to do the best for our patients and we want to be smart, but we don't actually look to see whether we're actually helping our patients. And here is one very good example of that. Some of you may be familiar with a tool called the Swan-Ganz catheter, the pulmonary artery catheter. This is something we used all the time in my residency training. Every sick patient, every patient who was in shock, getting fluids, on pressors, was getting a pulmonary artery catheter. You would be hauled in front of the authorities in morbidity and mortality conference if you didn't put one in. And it made you feel like you were doing everything you could. You felt like a very smart doctor. So here you are as a young doctor, and you've got, your pulmonary capillary pressure, your cardiac output. You've got all these numbers, and you get to sound really smart and say, oh, let's titrate the, dopamine drip to a cardiac output of 5.3 or whatever it was that we used to say. And it was a very expensive intervention that how could it hurt patients to know all of this really cool physiologic information about what was making them sick? Well, the truth is that this is an example of how just having more information, having great technology, spending more euros or dollars, and even if it's scientifically valid and exciting and plausible, and the numbers are precise and accurate, all of those things together do not mean that the patient will benefit. And I'll tell you now, in the modern critical care unit, you won't find a single Swan-Ganz catheter because randomized trials ultimately showed these interventions did not help patients survive their illness or live longer. So my old beliefs We're going to go through these. Precision oncology is revolutionizing how we triage patients with advanced head and neck cancer to therapies. Number 2, is immunotherapy a game changer for head and neck cancer? And number 3, tumor mutational burden or other measures of the neoantigens in a tumor are key determinants of immunotherapy response. These are 3 statements that if you make in a modern oncology setting, most people would agree with very strongly. Most people would champion these 3 statements. These 3 statements are all wrong, although very few people will say that. And even if you're not a head and neck oncologist, I want you to think about examples from what you're interested in or what your specialty or your area of expertise is that may be a parallel story of how our excitement for technology and information does not always associate with patient benefit. Let's start with number 1. Precision oncology is a term that we use nowadays for the idea that if you could molecularly, genetically profile a tumor, that you could match the right patient to the right drug. Find the mutation, target it, boom, cancer cured. And many people have championed this approach as a success. And you know, with this meme, I don't want to say that we shouldn't be shooting the 3-pointers, but we should at least look to see what happens before celebrating. So what happened? Are there any randomized controlled trials of that approach of precision oncology? Take tumors, sequence them, find the target, add a drug, do the patients live longer? There's only been 1 randomized controlled trial of precision oncology to date. It's a European study, the Shiva study published in 2015. It was a negative trial. Now you could say that's old-fashioned. We've come a long way since then. So more recently, Gustave Roussy, the Moscato trial, 19% of patients who were enrolled in this trial, they all had their tumors sequenced. 19% were matched to a therapy, to a targeted drug for the mutation that was found in the tumor cells. And the response rate, the percentage of tumors showing a response, was fairly modest. It was 11%. Keep that number in mind, 11%. More recently, 2 studies, an American study and a European study, studying a similar approach, molecular profiling, followed by basket studies or targeted therapy studies where you can have any type of cancer with a specific targetable alteration, 11% response rate in both studies. In the United States, the National Cancer Institute, the NCI, has been running a study called the MATCH study. These are the 3 best candidates, mutations in PIK3CA, the oncogene, FGFR, and HER2. And you can see the response rates on the right here, all very unimpressive, 0 to 8% response rates in these drugs. These are the best of the best. Now, my institution, we're big believers in this approach. Every patient who comes to Memorial Sloan Kettering with a new diagnosis of advanced cancer will have their tumor profiled on a targeted next-gen sequencing platform called MSK-IMPACT, 468 genes and copy number and chromosomal alterations. We've profiled close to 50,000 patients with this platform. And one of the things that we did a few years ago is we got all the disease groups together to answer the question of how can we direct care with this approach? So if you would say that of all those mutations that you find, many of which you don't know what to do with, we could say, okay, let's just look at the good ones, levels 1, 2, and 3. Mutations or alterations where there's some clinical evidence that a drug does something, that a drug can do something about that alteration. And so that's 37% of all the cancers. This is after our first 10,000. And for cancers that we think about in the head and neck arena, thyroid, salivary, head and neck, those numbers are variable. So thyroid does pretty well because that blue over here, the blue, these are BRAF mutations in papillary and differentiated thyroid cancer. And so they have an actionable finding. But of course, you don't need to do genomic sequencing to find a BRAF mutation. You can see that with a limited test for BRAF, or you can even do IHC nowadays. For salivary cancer and head and neck squamous cell cancer, the percentage of alterations that are targetable is about 25%. And in fact, going into greater depth for our patients and looking at them carefully, that number is actually 21%. So most of our patients with head and neck cancer, where we run the sequencing assay, do not have a targetable alteration that we can do anything about. Of those who have a targetable alteration, we work hard to find a clinical trial, a basket study that accepts patients with lots of different types of cancer with that alteration. But ultimately, only 10% of our head and neck patients end up having their therapy guided by this big sequencing effort. And of those patients, 3%, 3 of the 10, actually have a tumor response. So that at the end of the day, of all of these patients that we've been doing tumor sequencing on for head and neck salivary or squamous cell carcinoma, 3% of them experience a tumor response as a result of all of this sequencing. This is important as health systems think about sequencing, because in the United States, tumor sequencing is FDA approved. Most patients with cancer can have tumor sequencing performed and paid for by our health system. And in head and neck cancer, this is the expected return. So 3% rate of clinical benefit is how I would put it. We're good at finding the alterations, but few of them are actionable, and few of these therapies are actually able to help our patients live longer or live better. And so perhaps we need a different approach, right? Perhaps we need therapies that have greater diversity and plasticity and even memory, because we all know that targeted therapies that target an oncogene always lead to resistance. The tumor finds a way to escape in every case. Can we do better? Well, the answer is we probably can. We can probably do better because our bodies suppress cancer every day, right? The immune system does. The immune system is an amazing system, an anti-cancer therapy with, for example, more T-cell receptors that find non-self signals in your body than there are grains of sand on the planet, 10 to the 18th T-cell receptors, an incredible and unfathomable amount of specificity and diversity. And the result of this is that in the United States, if you look at targeted therapies and compare them to checkpoint inhibitors, T-cell checkpoint inhibitors for cancer, many more patients in just the last 5 years have become eligible for immune checkpoint inhibitors and indeed actually respond to these drugs. So is immunotherapy a game changer for head and neck cancer? Well, I confess, I always get nervous when I see the word game changer, because I worry about hype and I worry what's the backing behind that hype. And so this is The Guardian in London stating that nivolumab, an anti-PD-1 immunotherapy, is a game changer for head and neck cancer. And indeed, we use it as standard of care in the United States. And just 6 months later, you shouldn't use that word game changer, because here's the same word. It was rejected by the National Health Service in the UK because it was simply not cost effective. So I don't want to say that these drugs are low value or worthless drugs. They do extend survival for patients with metastatic head and neck cancer. The paper at the top is for nivolumab. The paper at the bottom is for pembrolizumab. These both target the PD-1 checkpoint that breaks on T cells that, when released, can unleash anti-tumor immunity. And patients do live longer with these drugs. This is, I think it's fair to say, the greatest advance in the treatment of head and neck cancer since platinum chemotherapy in the 1970s. And yet at the same time, you can see that, yes, the curves separate, and we do have some long-term survivors with a disease that we consider to be incurable, metastatic head and neck cancer. But most patients do not respond. The overwhelming majority of patients, about 85% or more, do not respond to these therapies. And that was the low-hanging fruits. Anti-PD-1 versus chemo for metastatic disease. As we've tried to harvest more from this approach, we failed repeatedly. So this is data from the ESMO conference just a month ago. At the top, a study comparing pembrolizumab to cetuximab, a very weak drug, in patients who are too old and too sick to get platinum chemotherapy. The hope was that immunotherapy would do better than cetuximab, a fairly, a very weak targeted therapy. Pembrolizumab was no better. On the bottom, a study of moving anti-PD-1 into the first line for patients with advanced stage head and neck cancer, but not metastatic, where we ordinarily would treat them with chemoradiation. So this is maybe oropharynx or larynx cancers. Does adding immunotherapy do anything? We were convinced that it would, and it's stone cold negative. So what's wrong with these approaches? Have we exhausted what immunotherapy can do for us? Well, really, some patients are responding, the majority are not. And you can see that no attempt is made in any of these studies to select patients who are the most likely to respond. And there's a reason for that, because if you're the drug company, you want what they call the broadest indication on the label. You want your drug approved for all of the cancer type you're studying, not head and neck cancers with a PD-L1 staining of greater than 49% and a tumor mutation load of blah, 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 blah. You want it approved for everybody. And so the drug companies take a gamble. They go for the broadest indication they can. And repeatedly in phase 3 trials, the drugs are failing because we need more precision. So I've just sort of bashed the precision approach of clinical genomics, saying it's not that useful. We need more actionable findings. I've just said immunotherapy is not as useful because we need more precision. We need to be able to find responders. Is there any way that all the data we get from clinical genomics could inform who we give immunotherapy to? Could immunotherapy allow all of that genomic data in 50,000 patients at my hospital and lots of patients outside of my hospital? Could it make that data more useful, more actionable? One easy approach would be tumor mutational burden, TMB. TMB is a term that is used quite a bit in oncology nowadays, and it simply refers to the number of mutations in the tumor cell, the number of somatic mutations per megabase in the tumor. And the biological background for this is very simple, and you can't get a simpler explanation than this cartoon, which is simply that if you have mutations, they lead to these abnormal peptides. And if any of these abnormal peptides make their way to be presented by the tumor cell, by the HLA or the MHC molecule to the immune system, CD8 positive T cells now see a non-self signal. They see that mutation in the tumor cell as an indication of foreignness, and they attack. And of course, each of these steps has to work perfectly, and it's more complicated than this. But you would think that having more mutations in your tumor would lead to a higher probability of one of these rejection antigens, neoantigens, being presented to your immune system. Think of mutations as the number of tickets you buy to the lottery. So higher TMB would theoretically mean a more foreign appearing tumor, a tumor that's more likely to respond if you took the brakes off of the immune system. So we looked pan-cancer. We looked at 1,600 patients at our institution treated with immunotherapy who had genomic profiling done on their tumors. And this was, I'm showing you this page because there were 53 authors from lots of different disease sites represented in this study, collaborating to understand whether that simple number, the number of mutations per megabase, could inform our decision-making. And in fact, we see that across cancer, if your tumor's in the top 10% of TMB, highest 10% of mutational load within that cancer histology, you do the best after immunotherapy, as opposed to the next 10%, as opposed to the bottom 80%. And this is what the data looks like within individual cancer types. One thing I want to call your attention to is that the optimal cutoff for what makes a tumor TMB high or TMB low is totally different across different cancers. So higher TMB is associated with better survival in most, maybe not all, in most types of cancer treated with immunotherapy, but that cutoff for what you call high or low is totally different. You have to know what it is for each cancer. And it's probably different based on what testing platform you use. So here's that data on the right after immune checkpoint inhibitor. On the left, here are patients who never get immune checkpoint inhibitor or before they get immune checkpoint inhibitor. This is a new paper that my postdoc Cristina Valero has coming out soon. And we actually see the opposite. So lots of mutations is bad if you're not getting immunotherapy, but it's good if you are getting immunotherapy. Within cancer type, in some cancers, we actually see that flip. When you go from not getting immune checkpoint to getting immune checkpoint, that hazard ratio flips from one side of 1 to the other side of 1. There's more to the story, of course. That HLA molecule has to present the signal to your immune system. So imagine an abnormal protein down here, okay? You got your chicken here. It gets chopped up by the proteasome into these constituent peptides, and these peptides have to be presented to the immune system by your HLA. Our class 1 HLA has 3 different molecules, HLA A, B, and C. And we have 2 copies of each. We get 1 copy from mom and 1 copy from dad. And so you can imagine that the more diverse your repertoire of HLA molecules, do you have 6 different or 5 different or 4 different or 3 or 2 or 1? Well, I guess you can have 3, right? Because these could be, the A could be the same, the B could be the same, and the C could be the same. So if all 3 are homozygous, you have 3. And if all are heterozygous, you have 6. But you can imagine you're going to present a more diverse set of peptides to your immune system if all 3 are heterozygous. And so this is known in the infectious disease literature that the degree of heterogeneity of your HLA that you're born with determines how susceptible you are to infectious diseases such as HIV and malaria. And it turns out that this is true for cancer as well. And this is really fascinating work done by Diego Chow, a postdoc in my lab, co-mentored with Tim Chan and other scientists here at MSK. He found that being heterozygous for your HLA at all loci was associated with significantly better survival after immune checkpoint inhibitor, even when adjusting for tumor mutational burden. So it's not just the mutations in the tumor that are important, but it's the mutations in the germline that are important. And what's great about tumor sequencing is that if you're using a platform that sequences both the tumor cells and your normal blood, you can get all of this information. We find that this is relevant for head and neck cancer. The degree of zygosity, heterogeneity in the HLA alleles is associated with a much higher likelihood of response to immunotherapy, even holding all of those other factors constant. And so we're just scratching the surface. We're just getting started, but these are different factors that influence how likely a patient is to respond to immunotherapy and can potentially help us to find responders and triage effectively. And so this is the last bit. In the United States, we have a health system that really does not consider cost effectiveness when approving drugs. Very different from NICE in the UK and from the European Medicines Agency, the EMA, and from the Irish health system. And so over the summer, the FDA in the United States, based on very paltry data, decided to approve pembrolizumab for patients with high TMB tumors. Now, I've just told you that TMB is a good predictor of response, right? Is this something we should use? Well, on the left, you can see that higher TMB, this is across 16 different types of cancer, 1,700 patients treated at our hospital. Yeah, the response rate does go up. But if you look at the ROC curve, plotting sensitivity against specificity, you'd like a good test to, I don't know, look like this or maybe better than that. For TMB, it's fairly unimpressive. It is a predictor. It has biological plausibility. And it's like that Swan-Ganz catheter. It provides you with information that makes you feel smart. But we don't actually know if this type of approach, approving an expensive drug for any tumor with high TMB, is cost effective or is going to help patients. So the cutoff in the United States as of last June is 10 mutations per megabase, which is roughly in the top 15 to 25% of tumors. So all of these patients are now immediately eligible for pembrolizumab. We looked at response rates across 16 different types of cancer at MSK, and yeah, the response rates are higher for some types of cancer, but not for all. In fact, for some types of cancer, the difference is modest or lower with high TMB. So I really think this is a very crude predictor. Moving forward, we're going to need to consider tumor mutational burden, but also some marker of the immune microenvironment. How many immune cells are in the tumor? How hot or inflamed is the tumor? And we're going to probably need to consider multiple factors. TMB alone is just not going to do it, despite the FDA approval and the wishes of Merck that makes the drug. I think it's premature to use TMB in this way. So I'm going to end here. The bottom line is, what do we bring to the table as clinicians? We have to remind each other and our translational science colleagues that it doesn't matter how beautiful your theory is. It doesn't matter how smart you are. If it doesn't agree with experiment, it's wrong. So this is Richard Feynman, who was a Nobel Prize winner in physics years ago. For us as doctors, the experiment is a randomized control trial. We need to insist on randomized control trials. The EMA does this far more often than the United States FDA does for a variety of reasons. And this is what we as clinicians need to continue to insist on. So that's all I have. I'm going to stop here and just thank the members of my lab whose work I have had the privilege to show you. Thank you for having me. It was a pleasure to join you all.
Thanks very much, Luke. That was absolutely fantastic. Great insight. And it's great to see that when the facts don't add up, well, you seek a new reality. Can I just ask you how much, if I attend your institution with a solid tumor, you're going to profile my tumor, is that correct?
Yes.
And if so, how much? What's the cost of that? So before we're even out the gates.
Well, so at our institution, it'll be done on an in-house platform. As a patient, you would not be charged for it. For many cancers, the insurance company will pay for it. I think the charge is something like $4,000. Outside of our institution, outside of a cancer center that has a homegrown platform, they're going to use a company called Foundation Medicine, which is desperate to break into the European market, where they're going to sell you a service similar to that. They're going to bill your insurance company, $4,000 to $8,000 US for the privilege of sequencing your tumor. Every patient with advanced cancer wants this test in the hopes that it will find a magic bullet. For some cancers, it is, I think, quite worth it. Non-small cell lung cancer, you're going to find a targetable alteration in the first line, and go to an EGFR inhibitor, a ROS inhibitor, an ALK inhibitor, BRAF inhibitor. And for lung cancer, I think that's kind of the model. Most cancers aren't like lung cancer, and so it is yet to be proven to be cost effective.
And how do you think, obviously we're in, well, I think all Western democracies, I think our health services are going to be stretched in terms of funding for the next decade or even 2 decades after COVID. Do you think that there will come a point where this is a cost effective approach for, even if it's affordable, will it be cost effective?
So to answer that question has many stages to it, right? And sometimes if you're outside of the field of medical oncology, you sometimes can look at it with fresh eyes, because I don't want to just know that I got a tumor response in a certain percentage of patients. For many medical oncologists, that's where the discussion kind of ends. We got a certain rate of tumor responses, we're happy. But that tumor shrinkage by 30%, which we call a response, that does not mean the patient feels better or is going to live longer. And so what we need to demand is not just response data, but actually show me survival data, overall survival data, or if you can't increase overall survival by a meaningful amount of time, show me quality of life data. Our FDA rarely does this. We have a very low bar for cancer drug approval. So this sequencing, it's not just the cost of the sequencing. That's a drop in the bucket. It's the downstream treatments that result from that sequencing. Oh, well, we found a weird P10 mutation. Should I treat with a PI3K inhibitor, says the community oncologist. He asks a couple of his colleagues and they say, you might as well try it. It doesn't cost us anything. The system pays for it. So it's the downstream consequences of this information that is like that pulmonary artery catheter. It's accurate, It's valid, it's scientifically exciting, but we have a long way to go to prove that anyone actually benefits from this, broadly speaking.
Great. Paul, a few questions in there actually on management of the neck. Now, obviously, when we're confronted with medullary thyroid, it's either a pre-thyroidectomy diagnosis if it's been made on FNA, or less frequently on bloods that might have been done, you know, or it can be made post-thyroidectomy, you know, after a diagnostic hemi. What is your what are the criteria for managing the neck? What alters your decision making in terms of the management of the central neck and the lateral neck electively, where you hadn't anticipated it before?
So that's a great question, and it's that can come up where basically what you're asking is a medullary that wasn't anticipated, and a diagnostic lobectomy has been performed, and now you're faced in an MDT with a medullary thyroid cancer. So what I would say firstly is that in that scenario, even in the T1 setting, up to 14 to 17% of those cases on the ipsilateral side, patients will have central neck disease, and also maybe up to 10-12% will have lateral neck disease. So I think like anything, I would go to the MDT in that scenario. The patient is going to require cross-sectional imaging. They are going to require a calcitonin level, I think, and a CEA level. I think that one of the things that you're going to have to consider in that scenario is on your analysis of that tumor, what the mutational status is. If that turns out to be sporadic, or if it turns out to be familial, if it's familial, well then there's a greater chance that you're going to have multifocality. So in other words, do you need to do a completion thyroidectomy? You do, and you need to address the lateral neck. Where it becomes more difficult, and Luke, myself and yourself discussed this after I think the World Thyroid meeting last year, is in the sporadic setting. If you have a low stage tumor and after your surgery your calcitonin level is normal and it's a sporadic mutation, do you need to go back in and do a completion thyroidectomy? And this has now been brought up, and some centers were red in the face arguing that no, you do not. However, for the likes of myself and yourself, Neville, we probably would go in, and even if the calcitonin level was, I see Babak Givy joining us, he certainly can add to this debate, but if the calcitonin levels were elevated, I think it's a no-brainer then, obviously. But I think for good bog standard treatment in that scenario, yes, I would do a completion, and yes, I would do a central neck. And if there was any suggestion on the cross-sectional imaging that there was a disease in the lateral neck, well, then obviously it's a no-brainer.
Okay. Any comments from across the pond? Luke, would you have an opinion on that?
I was going to ask you that question because Dr. Miyauchi from Kobe got up at my case presentation on medullary thyroid cancer at the World Congress and asked me that very question. He said, you've got a sporadic RET mutation negative patient with a small medullary. Why are you taking out the normal thyroid on the other side? And I was very happy to ask that question because yes, we do discuss this a lot. And in the scenario you've outlined, no, I would not go back and take out a normal thyroid for no reason.
Very good.
You know, I think that ties in. I think it ties in, Neville, in terms of, you know, how do we monitor these patients going forward? And calcitonin is king. You know, obviously we have cross-sectional imaging, but even if you have someone where you do a total and you do your neck dissections, your calcitonin is going to be what's going to guide you. You know, if you go to ATA guidelines, if 3 months after your surgery, your calcitonin levels are normal, your CEA levels are normal, well then you'll check it basically on an annual basis going forward. If after all your surgery, your calcitonin levels are, say, less than 150 picograms per mil, well, in that scenario, you're going to do cross-sectional imaging now or an ultrasound of the neck, and you'll probably do that on a 6-monthly basis. If it's greater than 150 picograms per mil, well, then you're going to look at you know, not just examining the neck, but you're going to do bone scintigraphy, PET scans, MRI scans of the liver, etc. So the calcitonin in terms of our surveillance and in terms of what you're talking about there with that scenario, that's going to be really important, as will the RET mutational status.
So, Paul, at what time do you check calcitonin? Do you check it the day after post-op, 2 weeks after, a month, 3 months? When's your first calcitonin? Because the patients, once they know that there's this blood test that you're going to be doing to surveil them, they're going to want to know the answer, what's going on yesterday.
Yeah, so I mean, per ATA, they talk about the 3 monthly calcitonin level. In the patient that I presented there, within the half-life of calcitonin, we did a calcitonin level. So we went from 27,000 down to 1,000. Now, when you have a calcitonin level of 27,000, you're not going to get biochemical cure of that. But we went to 1,000, and the next check we're going to do will be at 3 months, and that's where per ATA, that's the I suppose the optimal time to see where you're at with the patient.
Very good. Okay, Laura, I think it's time to hand the floor back to yourself, given the time of the evening.
Neville, thank you very much, and thank you, Paul, for an excellent talk. And I think the background of medullary cancer I found particularly interesting, and the oncogene link. And Luke, your fascinating story through precision oncology, immunotherapy, tumor mutation and burden. I'm a cochlear implant surgeon, so don't hear much about these things. I was also interested in your thoughts about randomized controlled trials. I think they are so important, and I don't know how difficult it is still to do those in the States. Certainly it's difficult here to do them. But I'd like to say thank you very much. It's a great honour and privilege to have you talk with us this evening. And I really look forward to meeting you in person in the college shortly. Hopefully we'll get through this COVID experience, and I really look forward to meeting you. So thank you very much for joining us this evening. It's been a great privilege and honour. And thank you, Paul, and thank you, Neville, and thank the background team, Porrick and Kieran and Pauline and Paula. So good night, and take care, everybody, and have a very good evening, and stay safe.
Thanks, everybody. Good night.
Thank you. Thanks, Luke.
Thanks, Luke. Thanks, Paul.